Steve Moran here with Senior Housing Forum, and I am chatting with Ian Morrison, who is, I don't know exactly how to describe you, just an expert in healthcare, long-term care, been at this for many, many years, and you're going to be speaking, you're going to be keynoting at the Nick Spring Conference in San Diego in like 25 days, right?
Yeah, exactly. Yeah, I'm a healthcare futurist, and I've been doing this a long time, but I'm more at the 30,000 foot level, and certainly not as expert as you, Steve, on the issues of senior housing and assisted living, but I've been in the health business a long time. I always, I'm a professional futurist, and my definition of a futurist is an economist who couldn't handle the calculus, basically. So I'm in the
I love that
sweeping generalization business.
So yeah. What I'd like to do, if this works for you, is I'd like to start by just kind of having you talk a little bit about the overall healthcare system in the United States, where it's at today, and then I'd like to move and have you maybe talk a little bit about your thoughts about where the senior living space fits into that system.
Sure. Well, I mean, I think it's an interesting time. There are a number of dimensions in which you can think about the healthcare system in the U.S. I mean, we've gone essentially at political level through this roller coaster of the last few years of the Affordable Care Act, Obamacare, and then attempts at repeal in place, and now we're in kind of a situation where we essentially have Obamacare in Republican hands, right? With a Republican administration in the White House and in the Senate. The change in the House, I think, in the last election sort of probably means that we've got stability at least until the 2020 election. But, healthcare is a political animal, and we are already seeing the Medicare full debate start as virtually every member of the Senate on the Democratic side seems to be running for president and having different flavors of that. So I think you can anticipate a lively debate around healthcare over the next year. Meanwhile, the administration, I think, is got a number of priorities around healthcare prices and around drug prices in particular, as well as fashioning the marketplace, and as to the degree they can in more kind of market principle lines compared to the Obama administration. So that's kind of like the political level. At the strategy level, I work a lot with stakeholders like health plans and hospital leaders. I think they have adjusted to the economic consequences of coverage expansion, and what that really means for, particularly if you're in a state where coverage has been expanded, you're basically talking about the good news being bad debt goes down because you're uninsured. The bad news is your payer mix is impaired permanently because you've got more Medicaid patients, and that is the story, I think, across the country. But the other broader story, which I think is on a longer term timeline, and I have a relationship with Levitt Partners. Governor Levitt is often quoted as saying, and I agree with him, that we're on a long march to value in healthcare, and we're only 25 years into a 40-year journey. So there is this mega shift from volume to value in healthcare, where we're not paying so much for units of service, but paying for the care of populations. And I think that is the mega shift to watch, and may have relevance, actually, may have real relevance for your field in terms of the role that senior housing and so forth can play in the continuum of care. So that's maybe a bit. Yeah, go ahead.
Well, so I think there are some of us who are fairly, or I'm not sure I fit in that category, so I want to be careful in saying that, but I think there are a number of people who are really pessimistic about whether we can actually have the healthcare we think we want and actually afford it with the aging population, and kind of the mess we've created. Certainly, the drug pricing is a part of that. But do you feel hopeful or worried or discouraged?
Well, I'm an optimist. I'm a Scottish Canadian Californian, right? Which gives me kind of a unique perspective. And I would say that having lived and worked and trained in other countries and in Scotland and in Canada in health policy, I would say that there's no perfect health system. Every system in the world sucks in its own unique way, right? I mean, they're all an ugly compromise. We probably have the worst value in the US because we pay so much more than any other country and have kind of indifferent outcomes. And there's many, many reasons for that. Question is, what is culturally available us to fix, right? And I do think that's been part of our challenge is other countries have come to solutions, but they probably are not as available to us because we believe much more in markets. We don't trust the government. We tend to like innovation and technology, even if it doesn't do us any good. So there's Americans are different from Canadians. And I say that I'm married to a Canadian, and Canadians describe themselves as unarmed Americans with health insurance. They have different values. So, but having said all that, I do believe that there is a potential long-run solution set that involves some kind of bipartisan compromise around, getting everybody covered and covering people with systems of care that are coordinated and managed. And I think they're really going to be around the public and private roles in that future. But I'm optimistic we can figure it out because we're going to have to figure it out. Demography is destiny, and you know better than anyone that we're a relatively young society. We're just embarking on aging quite rapidly. Other countries like Scandinavia or Japan are way ahead of us in terms of the percent of population in old age. But it's a real deal, and as somebody contemplating that next 20 years, it's very important that we get it right.
Yeah, and so when I look at, there's a lot of talk, and at the conference where you're going to be speaking, there's going to be a big focus on really looking at this coordinated care model. And one of the challenges that the senior living space has really faced is that the acute hospital and hospital systems have been king of the hill. And they don't just seem to care very much about us because I guess because they don't have to. Do you see them as king of the hill changing? And maybe going a little further, what if you see it changing? Do you see that impacting the senior living space?
Well, I think there's signals of that. The threads, I think, as I say, I spend most of my time with the very people you're talking about, large integrated health systems and health plans. I would say two things. One is I've been very impressed and surprised to some degree by the focus that many of the actors in the health system and indeed the administration, both the White House, Department of Health and Human Services, and on a bipartisan basis in the Congress, a growing interest in social determinants of health, right? And the acute care sector suddenly realizing something that we've known maybe for 40 years, and still for 40 years, that people's circumstances economically and socially dictate in large measure utilization of health services. And so that recognition, I'm encouraged, is happening across not only across parties, but across all stakeholders. And I'll give you some concrete evidence of elements of that. Kaiser, for example, has made some investments in housing quite recently. And again, in recognition, and it's not so much on seniors as far as I understand it, but on, related to their populations. But, as part of their kind of broader commitment to community health and social determinants and to population health. Another example might be my friends at ProMedica in Toledo, who recently merged with Manor Care and are taking a sort of long view of aging, and they very much are committed to a social determinants of health model. So you see signs of it. Certainly in the conversations and C-suites and boardrooms that I've been in with some of the conventional health players, we're having conversations about housing, transportation, and the role that plays, including for seniors, in a much more serious way than I've ever seen before. So that is encouraging. The question is, it's a kind of conversation where you all have been in this business for a long time, and they're suddenly turning the party, and I suspect that there's a lot of dislocation in those conversations where people don't really fully understand the kind of level of both the economics and reality that you know so well, Steve.
So, sort of taking that another step further, I think that at least initially, there's still sort of a sense that you've got to be super careful, either talking to healthcare systems or payer organizations, because mostly they're going to really take advantage, screw you, probably a little bit of a crude term, but there's sort of the sense that they're out to get you for whatever you can, and you've got this big power organization negotiating with, even if you're talking about the large senior living organizations that are just not very sophisticated and don't feel like they've got much power. So sort of given that as a background and how we as an industry largely look at that, and I would tell you that there may be two or three senior living organizations that have actually done a pretty good job of starting to do those integrations, but mostly people are looking at it and saying, how do I talk to these people and make sure that we have a place at the table and don't sound stupid.
Well, I think that's an important comment, and it does speak to both power imbalances in terms of just sheer financial scale, and the fact that to a large degree, I think these are, and I don't mean this in a pejorative sense, but acute care sector and health plans may have looked at the sector as sort of a necessary evil rather than as an active partner. But I think that I think that's changing for the reasons we talked about earlier, in the sense that people are recognizing that the circumstances in which patients are discharged, particularly older patients, has real consequences. So particularly when you look at the increasing amount of Medicare Advantage penetration in the population, which grows every year, accelerated a little bit this year, but not by much, and has grown remarkably, even though it's not really the favored policy positions of Democrats. It grew consistently through the Obama years. And also, I think, potential further demonstration projects related to dual eligible populations, which I think will further increase the likelihood of productive conversations between your sector and the traditional health plan and acute care sector. So I'm hopeful of that. But I think the advice I'd give is turn up, be honest, and don't be fearful. But, I think there's a lot to argue that your community knows a hell of a lot more about these issues than the hospitals and health plans they're talking to. So you've got knowledge on your side.
Yeah, and I certainly think there's great evidence, as you spoke to it, that the housing side has the potential to significantly reduce the overall cost to the healthcare system, and perhaps related even the pressure to access services. Kind of relative to that, maybe this is a little bit of a tangent. Do you see telemedicine becoming mainstream? Because it would seem like, particularly in our sector, that it would be a huge win to be able to have a doc on a box rather than in the building.
Yeah, no, there's no question, and I live in Silicon Valley, as you know, and Menlo Park, sort of ground zero of venture capital, and I would say that both on the private equity side and on the venture capital side, there's been more investment in digital health in the last few years than any, we're all-time highs basically in investment. So there's a lot of productive capacity being developed by startups and by mainstream players. At the same time, you got the big guys, Google, Apple, Amazon, all very interested in health-related technologies and tools that are fueling digital solutions and telehealth solutions. I think you're going to see some very interesting, and CVS, another group I'm pretty close to, all of these companies are betting significantly on a role that they can play with technologies enabling connectivity to the home in particular for telehealth, telemonitoring. So I think there's a very, very high interest in that. I think we've got to be careful not to overestimate the payoff because, a teleconsult, you still got to have a doctor on the other end of the line, right? It doesn't take away religious institutes for transportation, but there are ways in which it can be structured that are scalable. And I think one of the things the industry is very interested in is the potential for artificial intelligence, so that you are trying to get more productivity using solutions that are digital, but not necessarily simple telehealth, televideo type, the kind of interaction you and I are having now. Instead of being two humans talking to each other, that the patient's talking to a machine who is a little bit more scalable and perhaps a bit more consistent than I might be.
One of the things that we worry about in the industry a little bit, and I don't know whether it's found or not, so just be curious about your thoughts, is there's sort of the sense that we are, as an industry, not super innovative and creative, and so kind of just I wouldn't say it's a big issue, but sort of a level of nervousness that that Google or Amazon or one of these big technology companies is going to create something that's actually going to do damage to the post-acute space. Do you see that as a, and sort of, let me flavor that a little bit more, because costs tend to be lower at home, and people don't really want to go into senior living anyway, mostly.
Right. No, I mean, look, the upside for your industry is a simple demographic one. You've got 80 million Americans who are going through total body breakdown, death and dying, and aging in place simultaneously, right? And the tricky part is half of them have no money, right? Which creates a whole other set of issues. But that demographic reality is not going away. And I just was at a session last couple of weeks with one of the leading robot scientists in the country, and she was basically explaining to the group that robots aren't about to come and say that, what we really need is a robot that does activities of daily living support, and that ain't going to happen anytime soon. The toileting and walking and getting people in and out of beds is a very, very complicated thing to teach a machine to do. And so there isn't a glib technology solution there. Where I think where I think the industry may have see a disruption, it's my kind of little one-liner of what I call K and B. I think the sharing economy may produce solution sets in sort of, how could I put it, virtual congregate housing or whatever, where people are finding ways using social media enabled tools and sharing platforms to kind of share resources. And I haven't seen, I'd be curious if you've seen any entrepreneurs in your space doing that, but it seems to me that that's one area where we might see some innovations that could potentially be disruptive. I mean, there's a lot of bedrooms in America that are unused. There's a lot of capacity in senior housing who people are trying to live in place. How could you optimize that in a way that was interesting? So I'd be curious, Steve, whether you've seen anybody innovating in that way, but I'm not aware of anything at scale in that side of the business.
So I've heard some stories, and these are really anecdotal, in some of the big senior ghettos in Florida where folks have built senior living communities sort of on the outside of these, and they're finding that the age that they move into the communities are higher than the national average because the seniors are supporting each other longer, very informal. The one other thing I see that's it's really prominent in California, but I think it does happen to a greater or lesser degree in other states, is that in California, when you just go by license count of licensed assisted living or residential care buildings, about 90% of the licensed buildings are 6-bed small communities. And they've traditionally been kind of at the lower end, but I'm seeing more and more folks who are going to that 6-bed model and doing pricing charging sort of enterprise pricing because it creates more of a home model. And there are a few people who are kind of trying to scale. It's pretty tough to scale very big if you're doing it 6 beds at a time. But I think it's sort of one of the hidden things, and I don't know where that'll play. And of course, it becomes really hard to contract for that if you look at it from a healthcare system. So, but I do think it makes some sense. And one of the things I keep thinking, you look at California and the cost of housing, and if you could put an elder with a young family who needs some help paying for a house, it could be a pretty interesting thing.
Yeah, right. Exactly where I'm at. It's sort of a market clearing model for that. Now, there are some entrepreneurs I've run into who have sort of sophisticated kind of recruitment of health aides through a staffing and screening model, but that's slightly different from what we're talking about. But that's exactly where I was headed. You've got underutilized residential assets owned by seniors where there may be some sharing potential enabled a shared, economy type model, like an Airbnb type model. I think that's an interesting opportunity, but it's a trickier population than your typical, Airbnb crowd, right?
Yeah. Do you see any potential for the PACE programs to open up paying for housing as part of the package? It would seem like a huge cost saving.
Yeah, I mean, that's a very good example of how I think the broader policy dilemma of how far upstream on medical spend, out of the medical spend bucket, are we prepared to go on the social spend line, right? So there's a lot of health systems who are talking or doing relationships with Uber, and transportation, to get people to appointments. There's increasing investments in housing, and by a number of at-risk health systems. The question is, how far upstream are people comfortable going, and how much will be allowed by policy? I mean, there have been some movements in terms of Medicare Advantage, and as you say, PACE is another area where you've got the right alignment of incentives to think about using other solutions that involve housing. So I generally would be very much in favor of it, but there is a danger that you start sort of bleeding too much of the spending out of the thing it was originally intended to do, right? And that's part of the dilemma for policymakers.
Yeah, no, it's a tough challenge. So I know that you're sort of at this 30,000 foot level. So this question you may go, I don't know, but I want to try it for you anyway. As you talked about earlier, we've got this big group of people that's getting bigger that just can't afford the traditional senior living product of today. Do you have any thoughts beyond sort of the sharing economy about how we might figure out how to care for that population?
Well, I mean, again, I think it comes back to who's responsible for the risk on some of the other health, social service aspects. I mean, I think one of the things that we don't have good visibility on generally, but let me back up. In any health insurance pool, whether it's commercial or whether it's Medicare, there's almost a law of physics, which is 5% of patients account for 50% of costs, right?
Yep.
If you look at those heavy utilizers, and I suspect there's a similar deal with regard to some social service spending on those patients, that if we had visibility about that total spend, we might think, and a lot of categorical social programs as to help, well-intentioned programs to help seniors, that there may actually be better solution sets. I'm thinking of a very specific example where at-risk Medicaid program I worked with some years ago basically did the analysis of their frequent flyer, and it was a dual eligible population, frequent flyer patient who was constantly being admitted to the ER, brittle diabetic, classic spending, and spending on medical care was enormous. It turned out that the key vulnerability she had, she was essentially homeless. And so they rented her an apartment, and it didn't even have to be assisted living. She rented her an apartment, and her total spend just for the medical care system went down from about $300,000 in any given year to about $25,000. Right now, that was an at-risk health plan who had sophisticated analytics. Think about that if you're a county who has got a lot of senior health programs and senior support programs, really doing that kind of hot spotting of those heavy utilizers. So to me, it's a kind of a nerdy response. I mean, but I do think sort of realigning budgets amongst local and public authorities, realigning Medicaid spending and programmatic rules, realigning dual eligibles in particular, can maybe unlock some sources of funds to think about different ways of solving what is a medical/social problem.
Yeah, and it's so difficult because I know for a lot of people, the idea that you took somebody who maybe wasn't very responsible in terms of planning for retirement and say, well, we're going to give you housing for little or no cost, even if it's ultimately going to save the system, sort of feels wrong. A little bit like people who are sort of suggesting the basic income, right? And for a lot of people, it just feels wrong. But ultimately, from a societal standpoint, it would seem like you have to be practical and say what's actually going to get us the kind of care we want and deserve at the lowest cost to society. So, interesting question.
Right. No, it is, and it really gets to the heart. I mean, because you're just peeling back what is, I think, one of the overarching issues, which is that we don't really have a serious long-term care policy in this country.
Yeah.
Nobody wants to have that conversation, right? Because the number's too big, right? I mean, it's probably 200 or 300 billion a year of a benefit. When Ted Kennedy was alive, when Obamacare was being put through, he had the Class Act put in place, and it disappeared as soon as he died because, the implications are it gets to all the things you're talking about, but factually, better than anyone, the default long-term care policy for the American middle class is to spend down their assets and go on Medicaid,
and then go into often very expensive nursing care when they don't need that level of care. And so you're right. I just so listen, I appreciate your time. You've been very, very insightful. I look forward to your talk. And I'm so glad there are people like you out there in the world, because ultimately, it's folks like you who are thinking about this stuff that will change the world, change the healthcare system, and make it better. And so I'm just really grateful that there are people like you who are a lot smarter than me who are actually thinking about this stuff and helping us figure it out.
Well, Steve, thank you. You're being too modest. I'm going to make sure that I beef up on your website, and you've taught me a lot about the industry already, so I appreciate the opportunity to chat.
Great. And I look forward to meeting you in person in a few weeks in San Diego.